After morning tea, we're going to try and solidify everything we've spoken about and put it into etiology related groups so that you can derive some sort of care plan in the back of your mind to do to manage these wounds. So the most important part and the most underutilised aspect of wound management is debridement and preparing that wound. And a lot of the time, as I've said to you time and time again in this lecture so far, it's our role to prepare that wound for the products that we're going to apply. The wound products do very little if they're put on a wound that they're inappropriate for. And a lot of the costs in general practice are about wound care products. Doctors don't want to know. So if we can actually derive care plans that will save them money, that will bring in an income with item numbers, that will actually look at changing the way our model of care is developed, working with the PHNs, working with the hospitals to look at hospital avoidance programs, we as nurses will feel better about our job, and one day maybe our doctors might ask us or give us a pay rise. So wound debridement removes necrotic tissue, it reduces the bacterial burden, and it maintains optimal moisture. Now we know that dead tissue in a wound stimulates an inflammatory response, doesn't it? The white blood cells are trying to get rid of that tissue. So we need to be doing the same thing, whether it's through mechanical debridement, whether we kill the organisms with an antimicrobial, or whether we actually aggressively apply aggressive products, such as the salt products that we used to use, but I don't promote those anymore. But certainly looking at the hypertonic salines, they will reduce a lot of the debris from the wound. So there's an acronym called TIME that is used internationally, and it's looking at the 4 components of wound healing. What's the tissue telling you? Is it dead? It needs to be debrided. Is it unhealthy? It needs to be cleaned. Inflammation or eye. Is it inflammation or is it infection? And we'll be talking about the difference with those. Moisture. Have you got a fine balance there? Is there something other than just products applied to the wound that you can do to relieve the moisture? Compression. These days in wound management circles we say that you've virtually got to talk yourself out of applying compression to every wound, because you know that the wound is going to be edematous. The peri-wound area is going to be edematous when you are in the inflammatory response. So why not manage that with a little bit of compression? And then last but not least, the epithelium will actually migrate across healthy tissue. So it's our role to actually get that tissue to being healthy, to actually being able to keep healthy skin on the tissue. If your granulation is over-granulated, the skin cells will just wash off because the tissue isn't ready to actually be contracted. So we need to actually prepare the wound with this. We need to look at a wound like this. Okay, so you've got this wound in a groin. It's post-operative from following an angiogram. You've got bruising around the outside and you've got slough. The slough is not there because of infection. The slough is there because of the autolysing hematoma. So no matter how many dressings you put on that wound, you're not going to actually get it healed rapidly unless you apply compression. You need to apply compression so the body is then able to get rid of that hematoma under the tissue, and then the fluid will actually reduce and the wound will start to heal. So look at the difference between a wound that has compression. This is after 2 weeks. So compression, you've gotten rid of all of the hematoma around there. Dressing products aren't going to do that. And as you get rid of the hematoma, and as you've reduced the lymphatic drainage, you actually then start to have a healthy wound base. You don't need expensive dressings at this stage. You just need a tool, something like an adaptic, and a combine. Change when it fills up with fluid, and compression garments.
Yeah, can I just ask?
Yes.
In the vast majority of people we see with like an angio
Yep.
wound are older, and so with a compression garment, they're looking like a full-length leg.
No, just a pair of bike shorts,
Right.
like Spanx.
Right. Okay, because that was my next question. Is like in the groin, it's just a bit of a nightmare to keep creases out and all that kind of stuff.
It absolutely is. And you've got to watch, a lot of our older people, their fingers, they can't get a pair of Spanx up. But any form of compression is better than none. So, try compression of any sort, and by compressing that tissue, you actually treat that underlying hematoma and the damage there, and actually reduce the lymph drainage that's leaking out through that wound. So the non-healing wound, after 4 weeks, if you've got a wound that hasn't changed at all, you need to reassess. What are you missing out on? Have you got the wrong diagnosis? Is there an underlying autoimmune response that you haven't dealt with? Who should you refer it to? It's at the 4-week period that you need to refer it. Have you got a secondary tier clinic that you can actually refer it to? Is there a dermatologist in your area? When does the vascular surgeon fly in and fly out if you're out the bush? They don't want to see random things. But if you've done all your assessments and you actually send the referral promptly to the surgeons, they will make a difference and see them early, because they know that you've done your full assessment. They don't want to get a referral saying, wound not healing, can you help? That's not a high priority. Wound ABI of 1.8, 1.4 or 0.8, the vascular surgeon knows instantly that you've looked at the vascularity and maybe it's a high priority for him. Wound, venous in origin, biopsied with squamous cell carcinoma. The surgeon will see that promptly because he knows that it needs to be debrided. Okay? We need to look at debridement. As I said to you before, looking at the diabetic heels, debriding that hyperkeratotic tissue, just sloughing it back. Looking at ultrasonic debridement. There's a machine that's going to be down there on Team Medical. This device, if you're out in rural and remote areas and you've got a GP that has applied for the PIP procedural incentive scheme, and they can apply regional blocks, this will actually equate to an item number of $266. Okay, so it will pay for itself, and you clean the wounds. So you use a machine that transforms electricity into sound waves. The sound waves transform the fluid into bubbles. The bubbles penetrate down into the dermis, 0.3 to 0.5, so they get rid of the biofilm, but they also lift the dead tissue off the margin promptly. How often do we get, these lesions where you've got lots of dead tissue, you're trying to get it healed, you know it's been caused by pressure injury? You can actually get this off without damaging the underlying tissue with ultrasonic debridement. Very easy. How often do we get these surgical variants, flap repairs that just fail? You've got exposed dry skull that you need to remove in order to get this healed. Ultrasonic debridement removes the attachment of that exostosis on the top, and you get it off in the dressing product, and then the wound epithelializes. So this is all done in community. This is, it saved the hospital $900,000 in 18 months with diabetic feet alone. It was evaluated. So if you've got a hospital in the home or a secondary tier clinic, they need to have something like that. They need to have a Doppler. They need to have magnification glasses. Maggots do a great job. We buy them from Westmead Hospital. They come up frozen. We apply them to the wound. We create an environment that's more attractive to them. So you actually put a hydrocolloid around that wound. You actually apply the maggots into the wound while they're still asleep. Get some transparent film, put holes in it because they still need to get oxygen. Put that on and change the combines regularly, because if the combine fills up with fluid that's smelly, the maggots will go through the holes to get to the smellier area. So you want to keep the wound more attractive to the maggots. After about 3 days, you'll have 3 maggots left that are nice and fat, and all of that dead tissue has gone. Now, this is a patient that had a hospital-acquired pressure injury, HIV. So you don't really want to have this patient getting infected, and we know that maggots will actually decontaminate most gram-negative organisms and clean that wound up ready for the dressing products that we applied to start healing it. So you create that wound into being able to have dressing products stay in there longer. Once you've got rid of the swelling and the slough, dressing products can stay in place for up to a week. So let's look at skin tears and how they're managed. So we often see them coming into general practice 5, 6, 7 in a day. When we do a wound clinic in the afternoon, we usually do 30 patients, and a lot of them are skin tears. So, you know, we know the causes, but do we do anything about it? When you've got a patient that's had one skin tear and a fall, are you getting the occupational therapist to go into the home and do house assessments? Are you looking at shin splints to protect the skin? Have you told your patients about moisturising their skin twice a day? Stopping from wearing soap. Using soap, not wearing soap. God, wearing soap, what can I say? We know that as people age... Pardon? Yeah, exactly, who's been... Cheeky things. So as we advance in age, we're more at risk of falls. As we have more things on our plate and we're not concentrating and being in the moment, we're more at risk of falling. Females are more at risk of falling. You know, as we become immobile, we lose our balance. Mobility is really important to maintain that balance. There's a group in America that show that when you age, we lose our ability to stand on one foot and close our eyes. So we've got to be actually doing that all the time from 40 so that we maintain our middle ear stability and we're not at risk of falling. And sometimes I can't do it, you know, so it's really important that there are things that we can do that stimulate balance, okay? If they've got a history of skin tears, we know how we can reduce the impact of damage. Every dressing product on the market wants to get your business. So they all have these types of charts on types of skin tears. I don't tend to use it. It's more associated with research and to give you an idea. If you've got, you know, dead tissue, pointless trying to reattach the skin, but if you can actually feel the skin and there's still a bounce in it, 5 to 10 days after the injury, and it's still got a bounce in the skin, you've got a chance of it surviving, okay? So if you provide the right environment, we know that the skin derives all of its blood flow from the dermis underneath. So if you've got a skin tear and the skin is folded in underneath itself, that area there is going to die back because it can't get any nutrition. So what we need to do is actually get the skin back off the dermis, pull the skin out and treat it like a skin graft. Now we know if people are on warfarin, they're going to keep on bleeding because you've just washed the hematoma out, probably taken the fibrin deposit. So you need to actually cut that skin. The skin has no nerves, okay? Before you actually rehydrate it, you could probably put lignocaine, on that, wrap it in Glad Wrap, get them back in, and that moisture will actually help that to lift off. Then you can see that this wasn't done in a general practice. Only emergency departments can actually take a bottle of Prontosan to the wound base and then throw it out, can't they? Because we get a syringe, draw it up, and then get the syringe underneath that flap and squeeze the syringe so that you lift it off from the base. Then as you clean the skin off, you can see where the hematoma is, where it's been punctured and where the skin's been shaved off. So not all skin tears are skin tears. Some skin tears are punctures. So you will find that this area here is going to take longer to heal because you've got a hematoma there, but you can break the forceps open or use a curette and get rid of all of that hematoma underneath there, cut the skin, bring it to the edge, and you can see how much healthier it looks once you've got that hematoma from underneath it. Once you get the hematoma out, the skin turns pink because that's what it looks like underneath. But it looks like that when you've got a hematoma, and it's a much better outcome. This is a skin tear, you know, a week later, and they've been using Mepitel or Gelinet. But you can see that there's new epithelium there already, even though the skin is back in underneath itself. And the skin, despite the fact that it's wrapped underneath itself, is still viable. So you've got to give it the best chance of survival. Unwrap it, bring it back to the edge, put tulle on it, whether you've got Gelinet in your GP practice. Some GP practices only use Gelinet, so use it, because all you need in a skin tear is to allow the fluid to drain out through the wound, through the holes that you've cut in the skin, and to attach it to the dermis. You don't need high-tech dressings there because the body's going to do a job. That's the tissue, the dermis, is actually sticky. So as the areas that don't take of the skin, you just cut them off, just like you do with a skin graft. And then you'd actually compress from up at the shoulder down to the hand, because you've still got hematoma in the tissue, haven't you? So you want to manage that, and you want to manage the lymphedema. And you get the patient to just feather their arms from the end of the arm right up to the shoulder, the toes, back up to the centre of the body, because that stimulates lymphatic drainage, which you want to get rid of the edema, excess edema. If you're putting a dressing on that wound, never put a dressing on a wound until you've prepared it to have its best result. Our patients love waterproof dressings because they can leave it on, they can shower and do all of that. But it's going to cost them. You can give them a cheap dressing that your general practice can afford, or they can actually buy an expensive model if they want. But don't put expensive models over a skin tear where the skin is folded underneath itself and you've got a dirty great hematoma, because that's going to go on for months. You're wasting money and resources. Always put the arrows on to allow your colleagues that are following you through to take it off without actually tearing the flap up. If you manage a skin tear by occluding it, we know that occlusion leads to drawing in of white blood cells. What do white blood cells do? They break down dead tissue, don't they? So by having all of these steri-strips on and an occlusive dressing, you've got all of this fluid sitting here. What's going to happen when you take it off? You're going to peel all of that, the skin off that's on underneath the steri-strips, and the flap will come off with a hydrocolloid. All you need is a tool on that to hold the skin in place.
What's the thinking of how long to leave a tool on a skin tear at the moment?
Look, with a skin tear, you're not doing anything to that wound apart from attaching the skin to the dermis. You can leave it for a week. Okay, but you've got to look at the type of tool that you use. If you use something like Atraumant evaporates and it becomes really dry. So when you take that off after a week, you'll take the flap off with it. But there are cheap tools on the market called Ergo Tool, and it stays sticky. There's also another company on the market called L&R, Lohmann and Roche, and they've got a tool that's really cheap that doesn't ever dry out, and it's great. Gelinet never dries out because it's paraffin based, cheap as chips, but you need to actually have a couple of layers because the weave is quite big in Gelinet and you can actually cause bleeding when you remove it. But if you do 3 layers, it works quite well. All you need is something to hold the dressing in, the skin in place, and then a combine over the top, compression from one leg, one part of the limb to the other. Leave it for a week. Trial of life, and it will tell you where it's been punctured and where it's just been a skin tear. And it's not the products that you've put on if the wound gets worse. It can be that you haven't cleaned the organisms out of it, okay, and you get infected, but generally it breaks down because it's been punctured and all the small arterioles have been damaged. So it's got no blood flow, and that area where it's all been punctured will just die back. That's not because of what you've done to it, it's the trauma that's caused that, okay? So know what's going to happen. Key points for skin tears. Develop your own regimen. Talk to the GP about whether he wants you, when you get skin tears, to actually apply lignocaine, wrap it in Glad Wrap, and then call him in 20 minutes' time after you've removed the hematoma so he can see it, and then you just put a tool on it. So if you've got a protocol to follow that you've all agreed on, you can do that. Look at your resource folder. You don't need 60,000 dressings in a skin tear. You only need basics. And, you know, companies have protocols. But remember, companies have protocols that sell their product. You know, the more expensive the product, the more lovely the protocol. Keep it really simple. Burns. We know we can heal them, but should we? You know, if they're small and they're not over a joint, we can actually leave them for the first 3 days. What do we need to do in the first 3 days of a burn? We need to keep it from getting infected, we need to stop it from drying out, and we need to manage the pain. Now, what is the second question we ask when a patient comes in with a burn into the surgery? What are their other comorbidities? Oh, that's probably, yeah, it's probably the second actually. The third? Absolutely. Have they cooled it down? Because if they haven't cooled it down with tepid water, that means that the tissue or the whatever's causing the burn is going to go deeper. It's just like a coagulating egg. Even though you take it off the hot plate, the heat from the coagulum is just going to continue to go deep. So the first day you may not be able to sense how deep it is. On the third day, you may go across a burn and see if they've got sensation. If they're howling, you don't even need to do that because it's painful, so it's superficial. On the third day, if you take your dressing off and you've got all the hairs on the dressing, you know it's a partial thickness to deep, full thickness burn because it's just weakened the hair shaft, okay? That's one sensation that you can tell. You've got no pain and you've got a lot of swelling. So what we say is look at the ANZBAR guidelines. Oh my God. And most of the time they will give you good guidelines based on the size of the wounds and functionality. So hands, faces, feet, groins, the burns unit will take 1% burns in those areas. If you've breathed in a burn, a chemical, or if you've breathed in fire, burns units will take you. But these wounds don't require dressing products. You need to wrap that in Glad Wrap. You can see they've already cooled it down because it's completely macerated. But by the time they get to a general practice, they really should have been in the burns unit because he's lost his function in his little finger already. Okay, you can see that it's already contracted. And that's what's important for us to look at, the functionality that's ongoing. So in a burns unit, you will actually have different levels of burn. Where you've got bullous eruptions, they generally say you've got a partial thickness burn. But you need to look at functionality. All of these areas need to be moved all the time. This just took from the time it was injured to getting into the burns unit for that contracture and the loss of function on that hand. So that's a hand on a tradie who will never be able to use his little finger again. That requires skin grafting, and even though it's been skin grafted within, an hour of arriving to the hospital, that's never fully restored. Okay, it's heartbreaking, isn't it? Heartbreaking. Great outcome, and what are the main things that we do in a burns unit to actually enable functionality? We have compression, we have high protein drinks, we have physiotherapy and occupational therapy. So if we can't provide that in the community, we need to transfer our patients with hands, feet, groins and faces, okay? Most men will walk on water to get to a burns unit if they've affected their pecker, that's for sure. They'll be traumatised. Any form of trauma there. Parents with children will just walk over glass. Now, what's the most common cause of burns in children? Surprisingly, no. No? Camping. We put our fires out by putting sand over the fire. It's really important that we actually use water to put the fire out and then put sand. Just by putting sand over it creates a hungy, doesn't it? So we need to, when we're going camping, to actually put the fire out with cold water and then put sand over the top. We've educated mothers about tea and hot water spills and things like that. Our stoves have been changed, they're pyrotechnic now, so kids aren't burning their hands anymore by placing their feet on the hands on the oven. We've actually reduced the water systems, the heat in our homes, because babies were being burnt by hot water systems. But what's happening with the hot water systems now that we've got reduced heat in it? We're finding more organisms that are alive that we never had before. So, there's a cost with that. So always think, if you've got an immunocompromised patient and you're telling them to go and shower in their wound in the shower, we've got, there was recently at the Wounds Australia conference, they found in testing the water in the Sydney hospitals that there were organisms in the water that they found 20 metres below the sea in caves, alive in our taps and water systems, because we no longer have the heating, because we don't want to burn the kids. So think about that. We've got Pseudomonas in the water if we're not flushing it. So that's really important for our immunocompromised patients. So we need to identify what type of causative agent. Did someone ask something? No? I must have heard myself say. So the causative agent. Never get a concreter to wash the cement off with water because it activates the lime. You've got to put some sort of milk or acid on that, to actually equalise it. Ring up the poisons unit and find out how to actually stop the damage from the agent. Cool the wound down, not with cold water, but with tepid water, you know. Look at the size of the burn and contact the burns unit and say, look, I've got a burn here on a child, it's on a hand, it's on a forearm, over a joint, and they'll tell you, wrap it in whatever, send it up to us. Never use Fixamol on a burn anymore. Fixamol is not used as a primary dressing, but as a secondary retention dressing. You cannot use Fixamol anymore, or Hyperfix, or any of those products. As I said to you before, burns evolve. They may get deeper if you haven't disinfected them, and if you haven't cleaned them properly. If you're going to manage the wounds, they may get infected.
And another example of that are thermal burns. If you step into thermal, they evolve over 72 hours.
Electrical burns.
And then it's amputated.
That's exactly it. So, you know, if you know the history and you talk to the burns unit, they'll take them straight away. So they need to know the history, the age, all of that, and the first aid that you've applied. So I don't tend to go too much into it. So, but you can look at the ANZBAR guidelines and follow that. And look at the referral. Know your burns unit. Know your diabetes educator. Know your nurse practitioner in vascular. And they will know that you know your job. And develop your own protocols in your practice so that you know not to have a patient with a burn sitting waiting for service for an hour. Because what's going to happen for a patient who's got a burn that's sitting there without first aid? It's going to get deeper, isn't it? And you've caused that. So we need to have protocols that our receptionists know. This is a burn, this needs to be seen straight away. Okay? We need to cool it down. Now this is the piece de resistance, isn't it? This is looking at the symptomatology of a lower leg lesion. By far the most common are venous leg ulcers. 70% they say. It's really questioning about whether it's actually 90%, looking at that. How do we treat it? How does the body show us that something is going wrong, that we can actually develop a diagnosis related to this? So what are you seeing in this wound? It's unhealthy tissue, isn't it? So you've got the arteritis associated with Pseudomonas, whereby it damages the small arteries and it goes black and mucilaginous black. So you know that you've got an infection there, you know you've got moisture, so you've got to get rid of it. You've actually tried to compress it because you've excoriated all of that surrounding skin, just macerated it, haven't you? So you've had venous fluid sitting on this on this tissue for too long. You need to actually compress slowly. Don't aim to get rid of all of the fluid out of that leg when it's compressed. Send them home, get them to elevate their leg, and then just use tubular bandage. Slowly. Yeah, it does. But you've got to know what's caused that. And a lot of people look at something like that and go, oh, you know, it's the compression that's caused that. But it is, but we've applied it incorrectly. So we need to know that we actually can harm the lower leg by the things that we do, by applying things too early. You know, pointless putting silver on that dressing, on that wound. Why? Because it's an alkaline state. It's full of slough. Silver only works on a clean wound base, an acidic wound base. You'd be better using iodosorb to kill the Pseudomonas there, and a good betadine wash. Putting cream on the skin before you compress it to actually protect it from the wound fluid that's going to be squeezed out through that limb. But most importantly, just saying to the patient, look, you've got a limb full of fluid. I can't compress it today because it'll push through your wound. How about I give you 3 layers of tubular bandage, go home, put them on in the morning before you get out of bed, come and see me then, okay? It makes a difference, and I've got a photo to show that. So venous leg ulcer characteristics, they actually mimic the system that's not functioning, okay? So they've got brown, brawny edema because you've got cellular waste in the tissue. Long-standing venous disease, they have big calves that are soft, they're not muscular, and they've got really woody ankles. And that's because, as I said to you before, they've got fibrinogen sitting in the tissue that's actually formed fibrin. So they have reduced range of motion in their ankle joint. So they need specialised products to actually get rid of the fluid that's down there. They've got the lesions themselves are generally irregular shaped, and they're shallow, and they're wet. So you don't add moisture to get rid of the debris. you actually dry the environment out and the fluid stops leaking through the wound and it starts to heal. So compression, you can see the staining in this leg. You can see that it's a little bit woody there. The foot is quite flat. Sometimes in the initial stages you can use a zinc paste bandage because any form of metallic product will actually sequester all of the proteins into the zinc rather than burning the skin. So that's something that you can do. And a lot of people say to me, patients refuse to use compression. But if you do it slowly, you can actually coax them into this. Now, when you've got a leg that's full of edema and you've got a lesion that's actually leaking a lot of protein fluid, it's really, really painful. Really painful. So if you have your zinc paste bandages in the fridge and you put a cold zinc paste bandage from the base of the toes right up to the knee, just wrapping around itself, that's an Una boot. The patients will say, that's just beautiful. It actually makes it feel beautiful. Send them home and then get them to put the tubular bandage on in the morning. Wrap it in you've put one layer of Tubigrip on it that's far too big for what you need, and then get them to put the 3 layers from the base of the toes to the base of the knee, base of the toes, mid-calf, base of the toes just above the malleolus. You will actually get a reduction in the fluid that's in that leg.
Sorry, what weight tubular bandage?
You actually measure the leg and then you look at the box, and on the box they've got gradients associated with the size. The research that we quote, it was done by Carolina Weller out of Monash University, and her research program is easily found on the net, and she was using tubular form, and that's a special, well, it's a category of tubular bandage that's supplied by Sutherland Medical, I believe. So you can look at that online. The limitations with the tubular bandage is that sometimes it'll roll up the foot. Sometimes you can actually cut a hole in the bandage and put it around the toe so that it stays down the foot, or just tell your patients when it rolls up here, pull it down again. It's amazing, these little old people that just don't do anything because they don't want to do something that you've actually done. And then there's the other category that go home and just take it off and won't even look at it. So always tell your patients, if it bunches up there, you've got more compression over a small area because it's bunched up. This is a venous leg ulcer where they've been managing the wound and the exudate with dressing products, but they leave the product in the wound. Don't put products that leave particulate matter without washing them out. You can see all the bits of fibre in there. You don't need to manage the exudate externally. You manage the disease process with compression. That will make a difference. Not expensive products here. Okay? Arterial characteristics. Now, when you've done your care plans, what are the patients going to be saying before they've got an arterial ulcer? Sometimes a year, 3 years before they get an ulcer. I'm getting pain when I go to bed at night. I don't know what it is, but as soon as I get into bed, my legs hurt. Exactly. When I lie with my legs over the bed, it's much better. When they're walking to the mailbox, I can't walk around shopping centres anymore because I'm getting pain in the back of my calf. Claudication. They're all signs that those patients need to have some form of investigation to look at their blood flow. And if you do an ABI, if you go to Team Medical, they'll teach you how to do an ABI. An ABI machine is $5,000. You get a item number of about $56 back. You know, maybe a little bit more. They've got the readouts. It's nothing to do with me, but I know that it makes money. And you need to be doing these item numbers if you feel a patient's foot and it's cold. Okay? If you haven't got an ABI, send it to a vascular surgeon. Or write to the vascular surgeon if he's flying in to do something in your area about, you know, how far the patient can walk before they've got pain, whether they can sleep at night, they have to sleep in a chair or they're in a bed. This is a patient and it looks an edematous limb, and people get these mixed up with venous leg ulcers. But this is a patient that's got damage to his leg caused by just insect bites. He's got no blood flow, so they extend. And he's got his legs down all night, so he's got dependent edema. Sometimes the pain is so severe in these patients, they need to have some sort of spinal anaesthetic applied so they can actually elevate their legs. But these are the patients that if you get them in bed and the patient's family can do passive exercises, they will get blood flow to their leg that will enable them to elevate their legs. But they won't be able to elevate their legs with so much fluid because it will just cause too much pain. There's reduced blood flow and more increased pressure on this tissue. They really need to have to go to hospital. But do all patients want to have vascular surgery? No. So how are you going to manage these wounds? You want to stop them from getting infected. You always rehydrate an ischemic limb. You would just give the patient that doesn't want surgery and has no chance of actually healing that wound without oxygenation, Flaminol, out of the fridge. Cool it down, keep it moist, wash it every 2 days in the shower, and you can see that they've got Flaminol on these wounds. And the Flaminol, because it's a silver product and it dumps silver at 1,000 parts per million, will absorb the proteins in the fluid that's leaking through it, and it's a false slough. So if you get a sponge, you wash it off, all of that slough will come off it. It's just a common thing with Flaminol. Okay, you're not aiming at healing that wound. That patient's going to die from pain in this wound. So you just want to stop it from getting infected. If you don't have a Doppler, what you can do is get the patients on the bed, elevate their legs at a 90-degree angle, and watch the colour drain out of the feet. Okay? Then you put the legs down beside the bed, and if they turn bright pink, you've got a positive Berger's sign. So you've got an ischemic limb. So you can say to your GPs, look, I've just done a Berger's test, it's positive. And he'll say, great, you deserve a pay rise. Maybe. But you look at the toenails, you talk to the patient, they are sleeping with their legs down at night, they've smoked for 40 years, they may just have an acute occlusion where they haven't had any symptomatology. We get to know our patients with our care planning. We need to look at our 50-year assessments, capture these people at 50 rather than 80.
Sorry, Cheryl, how long did you say we're going to stick them up before we let them drop them?
A minute or two, you just watch the colour drain out of them. And what will you feel when you actually feel these feet as you lift them up? They're cold. Absolutely. They may even complain of pain as soon as they get on the bed and bring it up on the bed. So you really don't need to do a Berger's test then, because you know they're cold, pain on elevation, they've got ischemia. Dressing products aren't going to do the job. So venous ulcer management. Let's get back onto that. We know that there's blood flow. You never compress a venous ulcer until you know there's blood flow in it. Okay, you need to do a Doppler. And nursing agencies will say you cannot compress without a Doppler unless a vascular surgeon has seen it. If you've got a vascular surgeon that knows, or a GP who's confident in knowing how the blood flow works, you can then compress it. Doing it slowly, a little bit of compression that builds up over an amount of time is efficient and will do the job. We apply tubular bandage and we cover the costs of that. And they can be washed and reused. We put the 3 layers on before the patient gets out of bed in the morning. Tell them to do that. If they get pain after they've got 3 layers on, they can take the 3rd layer off and only have 2. If they can just tolerate 1 layer is better than none.
And after a period of time, after you try the second one again?
Absolutely. The key with all of this is getting the patients to change their lifestyle. You've got to tell the patients that you're applying this before they get out of bed. They can't have a shower first and put those on, because if they have a shower first, the fluid's back in their legs. It only takes 5 to 10 minutes for venous fluid to pool in the lower leg on dependency. So apply that and then put a bag over their leg, or just have a shower at night. So they can have a shower, take the bandages off and sleep without bandages on if they don't have wounds. Okay? We manage the fluid before they get wounds. This is a limb. The patient came in with a lesion here. He had bilateral swelling. We actually managed with 1 layer, sent him home, put 3 layers on in bed before he came out. We had a reduction in that leg of 6 centimetres. Look at the 2 lesions. This is a leg without injury. This is the leg with the injury, because we wanted to see if it would make a difference. 3 layers of Tubigrip makes a considerable difference. Every time you do 3 layers, measure just above the malleolus in that small part of the ankle and 2 fingers below the patella. And you will see a change in the circumference of the leg, but you will also see a change in the wound as well. If you compress too much, the fluid in the leg will squeeze out through the hair shafts and sweat glands, and the venous fluid will burn the skin. We've caused that, we get the cat's bum lips, and we're dobbed into the doctor. No two ways about it. These little old ladies love to dob us in, don't they? Well, the nurse actually did that. Beautiful. Now, we need to look at the etiology. So when we're in the clinic, we wash the legs down, as I've said, using just a Chlorhex sponge or a betadine sponge, depending on whether the patient's allergic to it. You look at this leg and there's lesions everywhere and they're dripping out, there's fluid, there's a lot of damage. When we go to the history, this is an old man that has a melanoma in the groin area, so he's actually palliative. So we're actually going to manage this nice and gently. We're going to put zinc paste bandage from the base of the toes up to just below the knee. Then we're going to apply Tubigrip in the thigh and then 3 layers of Tubigrip in the lower leg. So we cut the zinc paste bandage off, and it just treats the wound quite nicely over a period of a couple of weeks, because you've treated the swelling. You haven't treated the underlying disease in the abdomen, but you've treated the swelling in the lower leg.
How long was that bandage done?
A week. Yeah, absolutely. So we did that for 3 weeks. We sent this man to occupational therapy department, and they actually spoke to him about lymphatic drainage exercises, because the mass was causing pressure on the groin, so he wasn't draining. And just by exercising and doing his lymphatic drainage exercises, wearing the zinc and the compression, that wound healed. Okay? We can heal these wounds if we treat the underlying cause. And that was something like $7 a week. Value for money. That's all it cost him. But the same company that sells silver products sells these bandages. I bet you don't hear about the zinc bandages from the company that sells, Pro 4 and sells Acticoat and all of that. But they sell these and they're $7. A third of the price of, silver products. And you see patients coming in with little Mepilex products all on these little lesions. Oh, it's so expensive. Let's just take it slowly and gently. So venous leg ulcer, generally you will have a venous leg ulcer healed in 12 weeks, okay? When we sent these venous leg ulcers, there was a study done at the QUT in Royal Brisbane, and only 11% of patients came in that were diagnosed with a venous leg ulcer with compression. Why would that be? Patients refused to wear it, didn't they? So you've got to think about how you can get them into some form of compression, how they can afford it. And once you start reducing the amount down with tubular bandage that's not costing them anything, if they see the fluid come back, they'll think, well, it's probably time now to spend $40 for a week of bandages that get that wound to heal, okay? It's cajoling them and getting them to think. Sometimes patients don't realise how much they're living with pain until they've gotten rid of it. So when you actually have 3 layers of tubular bandage and you get them in the next day and they've got no swelling, you say, how does the pain feel compared to yesterday? And they go, well, it's actually a lot better. But people don't think about that. Sometimes we've got to make them a little bit mindful of what they're living with. These older patients are tough, old patients. Our generation won't tolerate pain. We don't like it at all. But the older generation, they tolerate it. So arterial, if you can't get a vascular surgeon, use iodosorb or Flaminol, paint it with betadine. If it's dry, necrotic areas on the toes or on the leg, just keep it dry and paint it with betadine until it dries off, because it's easier for the body to epithelialise underneath the dry scab than it is to take it off and go through the inflammatory response. Never rehydrate eschar, because dry gangrene will not lead to sepsis. Moist gangrene will lead to sepsis. After 3 days, dead tissue will actually have anaerobes in it.
Sure, sorry, just a little slide and aerosol paste if wet. If it was wet, we tended to put powder.
Yep, great.
Is that
Yep, absolutely. Yeah, I don't know. I probably did the wrong. I just probably put.
Dry
Yeah, that's just a mistake. So I probably was drinking the day that I did that.
So it's not right, okay.
Yeah, no. Powder to a wet wound, paste to a, if you've got a wet wound and you've only got paste, you just apply it on the gauze and then put the gauze on. Yeah, no, that's incorrect. I'll fix it up. Thank you for that. I've done this for 2 years and no one's ever picked me up on that.
Just because that's what we pretty much do.
Yeah, yeah.
I tell my colleagues, "Cheryl, we got it right." I said, "Yeah." So
you said drinking last night wasn't good for you.
I know. Exactly. I was wrong, clearly. Yeah. So here we are going to talk about the tsunami of diabetes. I've already said, in Australia, we've got one patient losing a limb every 3 hours. Oh, I thought it was every 3 days. It's every 3 hours. That's despairing, isn't it? And that's what I say to you when you're actually screening your patients for low risk, medium risk, high risk. There's no low risk in a diabetic foot once they've got diabetes. They're all medium risk. They're at risk of developing a form of lesion from pressure, a form of lesion from fissures as in drying skin, or just ischemia. So we need to actually get them into an appropriate regimen. So when we look at the changes associated with diabetes, we've got sensory, that they can't feel. So when they're walking with their toes curled up and they're just walking with two sensations of just clomping down, and they develop callus. If we leave the callus without shaving it back, they're going to actually break the tissue between the callus and the bone, and it's going to go down into the bones, okay? We need to know that with diabetes, they have changes in their temperature. So a diabetic foot won't show the same signs of infection. You won't get redness, you won't get heat in a diabetic foot, even if it's floridly infected. Once it's showing those signs, you've lost the foot, okay? So these wounds, nothing is too small to actually be sent to a high-risk foot clinic or to collaborate with a high-risk foot clinic. So injury is caused by shoes that are too tight, socks that are too dry, the patient not applying cream to the fissures in their heels. What sort of cream do you apply to heels in a diabetic foot? Calmurid. Or you would use something like, Calmurid's the best because it really gets rid of all the hyperkeratotic tissue.
That's
ID, yep. And they've got to do it every night. You've got to get family members to look at their feet, because when they've got changes to their feet, they've also got changes to their eyes. They can't feel, they can't see. Sometimes just a mirror on the floor, if that's all that they can do, if they live alone. 70% of diabetics have neuropathy, and it can be one of the preceding symptoms. The motor changes. The bones are dropping. You've got the calcified arteries. You've got, the flexor muscles aren't working anymore, and the bones all drop. So you've got clawed toes and callus. Look for this. Look at people at 50 and see the changes in their feet. I went on a cruise up in the Northern Territory, and we're all walking up this gorge, and we've all got our walking boots on and socks, and we're aware of all the pebbles. And there's this one man, 50, barefoot, going really tough. It doesn't hurt me, doesn't affect me at all. Mate, you've got signs that you've got neuropathy in your feet, and then coming down the hill, he's knocking his toes, and then, in the boat, he's got fissures on his heels. And I said, mate, can I just take a photo of your feet? It's just shocking. And I said, you're really at risk of diabetes if you've got no sensation there. And, he drank about, 5 drinks. Not that you become strange in wound care, don't you? Who bothers looking at people as they're doing that on a boat? But, he couldn't see properly. And he was one of these jovial men. A touch of sugar, that's exactly it. These jovial men that laugh about things that, we'd be really worried about, because he's got frontal lobe changes as well. As we wave them off in their thongs fishing, see ya, goodbye. How do we just do the dance, get into our pyjamas, watch TV, do whatever we want? Yeah, I know, men. But, men would say women are equally as bad.
No, I've got some,
Oh dear. So we've got all of those changes, and then we've got changes associated with the autonomic sensation. They're not getting the white blood cells to break down and fight off organisms. So they're more at risk of infection, but they're not getting show the signs of clinical infection. They may smell, that may be the first sign. The medications associated with diabetes these days are so good that they don't get the peaking and troughing anymore. Remember in the old days we'd know if a patient had their blood glucose peaking and troughing, oh, you've got an infection somewhere, and you look at the wound. Nowadays it remains constant because they're, moving it around to suit their readings. So we need to look, they've got reduced cell function, reduced cell nutrition if it's ischemic as well as neuropathic, and they're more at risk of poor healing and infection. All of these symptoms together, when they've got a wound, they're in the catastrophic category. It's a catastrophe for a break in the skin on a diabetic foot, okay? Because that damage will lead to renal impairment. There are scales that you can use that sort of give you an idea when you're talking to a high-risk foot clinic about things that you see. It's more research-based, that. But we need to look at, the screening of high-risk of feet. People at great risk of developing chronic diseases. Why not do the 50-year assessment and do all of these tests, the Semmes-Weinstein test? Look at the skin, the diabetic wound, the 5-cent bone scan. You put a probe in there, down into the area that's unhealthy, and if you get to the bone, you've actually got osteomyelitis. This is a man with 2 toes missing. These people need to be seen after they've had amputations every 3 months. A care plan, evaluating them. This is a man that didn't go to his GP and then turned up with that. What happens? We just almost have a heart attack, don't we? Because we know he's going to lose another metatarsal head, probably a 4-foot complete amputation, and be at more risk of death because of the propensity to having an anaesthetic and renal impairment associated with that long-standing inflammatory response to damage. So a lot of the dressings that we were using back in the 90s mimicked healing. So, we used to use Caldestats and things like that, but Caldestat can dry out, and under the pressure, it looks like skin. So you've got to make sure what they've put on a week ago is diagnosed and you take it off so that you can see the wound. Superficial wounds don't exudate enough to macerate the tissue. When you've got maceration in a superficial looking wound, you've got a sinus down to the bone, okay, that you just haven't found yet. So wound infection, this is just practical points, and we're 20 minutes away from me stopping. Isn't it fabulous? You've done well.
Sorry not to extend it. The last picture, so you said if it's got maceration, are you meaning only the foot?
Anywhere. Look, they're not so much at risk of the vascular changes. It's more to do with the lower limb and the fact that we're dependent edema and we're shearing. Okay, there was a study done recently looking at pressure, because a lot of the pressure we've done just on people standing. We haven't looked at them walking, but there's no difference. It's just all the amount of the total body surface being placed, all the pressure onto one particular spot. And that's where orthotics work, because they place all the pressure around a greater body surface, not just that one spot. And that's why they need to know people like this have got injuries, and they need to maybe have a full contact cast that they can't take off, because just walking to the toilet is enough to damage that tissue. No mobility on those limbs.
Can I ask, when you said about referring to podiatrists as well, I constantly get reports back from podiatrists that they'll assess a diabetic patient once a year for diabetes complications. The rest of the time they're doing toenails or whatever. And that once a year report will say this patient's at low risk of developing complications.
Yeah.
And it seems to be a bit of a standard this last probably 2 or 3 years. That's the kind of information we get back. They do a Doppler, and if the Doppler's inside normal ranges, that's
not good enough.
Response.
Yeah. Look, it'll all change. If you guys get Dopplers and the podiatrists aren't getting paid for doing Dopplers, and you get them in to do case conferencing, it will all change, because the doctor wants answers to what's going on with this foot. And if a podiatrist has a look at a foot and says it's low risk without applying any form of offloading in a foot with a claw toe like that, they're actually not obeying the duty of care. So a foot with a toe like that is high catastrophic risk. So,
depending on what you do, we've had a few that are a bit slack too, where we've referred through the care plans or haven't got reports. And I've actually rang them and I said, Fred or Mary, whoever it was, you want us to keep referring to you, you need to provide the care, because there's plenty of other podiatrists that can refer to.
that's right, they're not doing their job, or they don't know. Because all of this information is changing on a weekly basis. It's just all of the research. So you've got to know, and some podiatrists are only good for cutting toenails. You know what I mean? So you've got to also screen what podiatrists are good. Some podiatrists lead to wounds getting worse. So you've got to know their outcomes, and that's where a high-risk foot clinic is more knowledgeable about who's who in the zoo in the community, because they're aggressive podiatrists and they're highly skilled. So you've got to know the skill set of who you're referring to, and if you're not getting the outcomes associated with preventing this from occurring and they're not shaving it, you don't want a podiatrist to see this every year. You want a podiatrist that's going to be shaving that hyperkeratotic tissue on a weekly basis and moisturising and getting rid of all of that damage before it becomes a wound.
And how long would you recommend that lasts for? Because I have an 84-year-old diabetic patient who would absolutely walk on a cold foot podiatrist. She comes to us for wound care and she's not driving 250 kilometres each way a day to go to Canberra to see her magic podiatrist, and we can't convince her to do anything else. And he's been managing this ulcer on her great toe for about 8 months.
See, that's unsatisfactory, isn't it?
What do you really
I don't know.
about falling into account and say, I've just been to this thing? I don't think it's best practice. I'd have to nothing.
I'm so worried about it because she's a very healthy, well 84-year-old, has diabetes, but needs to be stayed.
You've got to just look. Sometimes podiatrists and vascular surgeons will do very little because it's end stage ischemia. So by keeping something dry with a betadine soaked with a betadine or an iodosorb, it's where they're hoping it's a trial of life really for the epithelium to migrate underneath it and to dry and then it come off. Even some toes, you'll see some vascular surgeons that leave the toes that are black and dead just with betadine and hope that it just falls off in the bed and that you've got epithelium underneath it, because it's a better outcome than taking them to theatre because they're at such great risk and they're poor surgical candidates. So you've got to talk to your vascular surgeon or the podiatrist, and the podiatrist may be under a vascular surgeon who said, this is a trial of life foot. They're eventually going to lose their foot. That's what I would be thinking. If they've had it for 8 months and they're doing nothing about it, you know, ring them up and find out and say, you know, what's happening with this toe? You know, why are you doing this treatment? And they may say their vascularity is so poor and they're just poor surgical candidates that we're hoping that it will just drop off.
She's got a very healthy looking foot and she's a very healthy looking.
See, I hate to think that clinicians are doing the wrong thing without actually...
She gets in her car and drives her 86-year-old husband to Canberra back and forth.
Gosh.
Once a week. She can't go.
Look at the standards. I would be looking at the standards, look at Diabetes Australia, fax it down to the podiatrist, ring them up, ask them why they're doing that, and if they don't say, well, this is what the standards are telling me, so why are you doing this? And you can't actually talk to the patient and say your podiatrist's not doing the right job. The same as you can't say that about your doctor, but you can cajole them into a different care plan, can't you?
A little bit of vulnerability. Are you aware she's driving 250 kilometres? Have you got a colleague in the area that you could refer her to? Unfortunately, you may have known her for about 20 years. Yeah, but still, I mean, she's convinced.
But we all have these patients that have got this random regimen. So let's look at... It's true. It's wrong, and you know, we need to look at reducing inappropriate antibiotic use in the lower leg. Antibiotics generally are the last thing that we need to use. if we maintain a cleansing regimen at the early phase when the wounds first come in to see us, we wash the wound down, we have the antimicrobial on that wound for 10 to 15 minutes, we kill the organisms, we continue to debride and debride and debride, we know the patient has vascularity, we can actually stop the microbes from increasing in numbers. Sometimes the patients come to us at this stage, don't they? Where their wound is painful, it's got pus draining out of it, it's expanding in size. At that stage the horse is bolted, the patient goes into hospital, and there's a lot of evidence to show that, you know, a lot of the diabetics with infected wounds have never had multidisciplinary management before, which is an indictment on us in general practice that we haven't done a case conference on all of our diabetic patients. But we need to actually educate our patients with diabetics before they've got a wound. Tell them that their white blood cells don't work. Tell them that they're more at risk of infection. Illuminate to them the other things that are going on in their feet. Not only can they not feel, but they're not actually producing sebum to moisturise the tissue, they're more at risk.
Given that most practices are money-driven, as opposed to higher up tertiary and public sectors,
Very controversial there.
I use that diabetic cycle of care, which they're phasing out.
Absolutely.
To reiterate that regularly, because a lot of them, the ones that actually listen to me go, yeah, I know, but look at my foot, I've got to do this, anyone's a problem, blah, blah, blah. The ones that come regularly. And then if you find there's an issue, use the 10917, which we haven't been using much.
No.
To focus on whatever you think went over their head or they need clarification.
Absolutely. Look at the item numbers. Use the item numbers.
The doctors won't let you see just because it's been practice.
No.
Irrelevant.
And a really good point is actually going to Kim Pointer's class this afternoon on Medi-coaching, and she goes down to the finer points of item numbers. And we need to be using our item numbers for care planning and all of those. Well, the diabetes is going now in 2019, but we're going to have other ones. Exactly. But we need to actually remember, when we get a wound in, where is the wound at? Is it in the inflammatory response? Can the patient's body tip the wound out of the inflammatory response into proliferation? If it can't, we need to debride, don't we? We need to actually manage these wounds by early detection and management. We need to actually apply dressing products that will kill the organisms. We need to kill the pain so that we can wash them appropriately and have the contact time of an antimicrobial on for 10 to 15 minutes. Then we don't need to use expensive dressings. We can use iodosorb, drawn up in a syringe, applied to the wound, put the lid back on, put the iodosorb back in a pathology container, send it home with the patient. They've bought their own. Okay, that's what the standards say. So we need to think about what disease process has the patient got that may place them at greater risk of infection. That foot with the ulcer, that they'd been walking on the rocks and they lost their thongs and the oysters had cut their foot. You know, we know that it's down to the tendons and the small bones. That needs to go to hospital. We don't worry about a wound like that. We need to get them in to the hospital. So think about what we do. In a healthy wound, if you were to swab that wound, you would get organisms. You'd get staph probably. But if you've got staph on a wound like that, would you heal it would you treat it with antibiotics? No. Would you swab it? Should you swab a wound like that? No, you're wasting money. A wound like that is just going to heal, okay? You need to just put a dressing in place. You've managed the fluid around the outside. You've got compression going on there. You can see the dressing product's a little bit compressed there. Not so much evidence down here, but you can see a few striations down there. You've managed the edema well. It's got little bits of epithelium growing over from the edge. A foam left in place for a week. Zinc left in place for a week. Tulle left in place for a week. That will actually continue to migrate and start to heal. A wound like this, you need to ask yourself, are we compressing it? Was it sloughy the week before? Sometimes venous leg ulcers, if their stockings are getting old, will start to actually develop slough. Because a venous leg ulcer, it's all about the fluid leaking through the wound that's causing that slough, not necessarily infection. So you need to know the difference. And the thing that you look in this wound, it's not necessarily infected because you've got islands of epithelium there. That slough is dry because you've actually gotten rid of the fluid that's keeping it moist. And you'll be able to peel that off soon. A nice afternoon with cheesy slough. Peeling, peeling, peeling. Very nice. But in the meantime, You need to keep it from getting infected and continue with your compression, okay? If you think it's infected, you need to do the Levine method. Now, when you're doing a swab, you actually need to look at the area that it's not healthy, where the granulation is purpley blue, for example, or dark in colour. You get the swab and you actually you massage around the wound to get the fluid that's under the surface up through it. And then you put the swab down at quite a bit of pressure and roll it around just a 1 centimetre area, getting the fluid up from the base. But you wash it down first, not with an antimicrobial, just with saline, and then you do the swab. You don't want all of this gunge on your swab because you get a false positive reading. You don't need the organisms on the surface. You need the organisms underneath the surface. They're the ones that are causing the problem. So why not think about a biopsy and where it's not healthy? But this wound looks to me like it's actually healing rather than getting infected. So know the difference. If the patient's not complaining of pain, if the patient's not got increased exudate when previously they were healing, if the granulation's not bleeding, maybe it's just slough and the person that's actually done the bandaging has been kind. Kind nurses don't belong in a wound clinic. You use pain. You're a bit too bright for my liking over there.
My money's worth. One of our local high-risk clinics and workplace centres, Scotland have it now, a lot of wounds there using anti-inflammatory cortisone creams around the periwork.
Just to reduce that burning, because it's a systemic effect, and that's just.
I just wondered if that was...
We do that, absolutely. If you've got a lot of overgranulation, sometimes you just need to use a little bit of steroid cream.
They're not infected.
Treat the cause. They're inflamed.
Yeah.
Absolutely.
Doctors kept saying it's infected, but that's...
Not, and that's the difference. We've got to look at inflammation versus infection. And, you know, if you've got a lot of edema in a lower leg wound and you've got excoriation because the fluid is burning the skin, it looks like an infected wound. But there's no pus. There's no heat and swelling. But you'll have redness in a leg that's full of fluid, won't you? And what did I tell you before? How to tell the difference between venous engorgement and cellulitis. What would you do? Elevate the leg for 5 minutes. If it remains red on elevation, you've got cellulitis and you can feel it. But you'll generally get a bit of warmth from a limb that's fully engorged with venous fluid. So always try compression and antimicrobials before you go on to antibiotics. Okay? School sores and infections, then you need to use antibiotics, don't you? Whether it's creams, but you need to get the whole family to wash their skin, don't you? You need to get them to all wash their skin because something like this, misery loves company. Everyone in the family's going to get it. You know, kids don't wash their hands, do they? Efficiently? So we need to look at, you know, how does it occur? It's all about the migration and multiplication of organisms and the host's response. So people that are more at risk of developing an infection are people where their white blood cells aren't functioning, where they're malnourished, where they're old or sick, with multiple comorbidities. So we need to be mindful of their risk factors when they've got a break in the skin. And we don't wait till they're dead to get them into hospital, do we? You know, once they've got lymph... Yeah, well, yeah, once you've got lymphadenitis and all of that, they need to go into hospital. So, you know, we just... Yeah. So identifying infection as opposed to inflammation, looking at nerves. It's not healing. The exudate's increasing. Is that because of the etiology or is it because you haven't started compression? It's red and bleeding. Is it red and bleeding because it's getting infected or because they're malnourished? Debris. Is it spreading because you're not washing it properly and you're leaving particulate matter in the wound? Does it have a smell because you've got particles of dressing product in the wound and you're being too gentle? These types of wounds, if you were to swab that wound with all that dead tissue, you'd get a false positive reading. But the tissue isn't infected there, it's actually damaged because of pressure. You need to cut all of that dead tissue out and then you need to do a swab after that. This, you migrate to see, you see if it's actually getting worse or better. Size, is it increasing? The temperature, is the patient getting sick? There's nothing worse than being infected. You know, have you probed to bone if it's diabetic? All of these things would indicate that that's an infection. 4 of those symptoms, you need to do something about it. Wash the whole limb, wash the area where the wound is, use an antimicrobial. Have you done all of that? And it hasn't worked, you go on to antibiotics. If you haven't done the cleaning and the antimicrobials, you don't go from antibiotics straight away unless they're really unwell. Okay, lymphadenitis, increasing cellulitis, all of that you need to actually use antibiotics. But think about all of these things that we can do. We can optimise the host response early. We need to know our patients. We need to know if every time we see them they're actually feeling unwell because they're lonely. You know, we need to know whether, you know, they're not eating any food, they're giving their Meals on Wheels to their pets. We need to know, you know, how can we reduce the bacterial load? And I've said it's not just about anointing a wound, it's about mechanically washing the wound. Having a secondary tier clinic that we can send the patients to, that they've got an ultrasonic debrider. Out west, you need to think about getting an ultrasonic debrider if you don't have surgeons out there, because you can get the PIP procedural incentive, and that will actually clean a wound. You need to optimise the wound bed, debride. And then general measures. All of these things that I've been talking about. Hold the patient's hand. Get to know them. Spend the time when you're doing your aged care assessments and all of that, and, you know, it really makes a difference. They trust you. And then managing infections. We don't always need to use the expensive products. We can use a product like Flaminol that will dump 1,000 parts per million for 3 days to kill the organisms and get a wound to heal. So when you look at this wound came into the vascular clinic, okay? So it's got the arteritis associated with Pseudomonas, it was smelly, you've got edema in the leg, and it's got a failed FEMPOP bypass. We get the betadine swab after we've put the lignocaine on, swab the wound. What do we see? All this particulate matter, because they've been using Aquacel AG in the wound and not taking the dressing product out. You know? If you're using fibrous dressings, you've got to wash the fibres out of the wound because they become the nidus. Why bother using $30 dressings when you can use Flaminol? So we got it to this stage, I had to peel all of this debris out of the wound, which I tend to like doing, ultrasonically cleaned it, and then we just put Flemazine on it. No antibiotics, Flemazine, and the patient did it every 2 days.
Did the lignocaine, was that enough local for you to do that on that size wound?
Yeah, absolutely. You can't, if you look at the instructions with lignocaine, you can't use any more than 7 centimetres of it. So you need to measure that. If it's a wound like that, and you could put about 20 centimetres on that, but you actually just spread it onto gauze and then put the gauze with. You don't need a lot of pain relief. They say you're more at risk of getting cardiac arrhythmias if you use a large amount of the lignocaine. In 20 years, we've never had any reaction to the lignocaine. Sometimes you might have a little bit of lightheadedness, but, you know, that can be because we've had their feet up and all of that. You know, I don't know, but no cardiac arrhythmias.
And our doctors are fans with doing like a course, so with lignocaine with adrenaline on bleeding.
Yeah, that'll stop the bleeding. Great.
Yeah.
Oh, using lignocaine with adrenaline. Really important to stop the bleeding, because if you compress the leg directly over the wound, you'll get bleeding down into the compartment, and you'll have this really large hematoma in the muscle compartment. So
anesthetic doesn't work so great then.
it's only 1%, and it's superficial, whereas an ointment penetrates deeper into into the tissue.
So can we make an ourselves?
Yeah, we mix 2% with some salsa.
Oh my God, you guys are just going to get me into trouble. I can't talk about anything apart from TGA approved. So, yeah. So anything I don't know, I'm not going to say.
Yeah, so we use 2%.
Oh, good on you. Oh.
There's 2% away into some salsa, mixed up, overnight, pop the bladder up or a Tegaderm, whatever, over the top, leave that up.
That's exactly it. That did not come from the floor. But if it works and you're evaluating it, Sometimes with the lignocaine, you may get an area where you get blue discoloration around the area. You get a little bit of ischemia of the small vessels. That's okay. It doesn't generally hurt the patient, and it goes very quickly. But flemazine, after that, we've cleaned it up. Flemazine, weekly dressings. We have a weekly clinic with a vascular surgeon. No antibiotics. Treated the cause, got rid of the debris, hit it with an antimicrobial, not expensive. Patient loved the flemazine, the coldness of it coming out of the fridge.
Flemazine or flavanol?
Flemazine. Flavanol is an alginate that uses a peroxidase effect in a cream. They're great, and they can actually reduce infection in the early stages, but flemazine dumps 1,000 parts per million of silver. You only need 3 applications of that and you've got the organisms killed. You've got rid of the debris. So in conclusion, don't you love this?
You think I have to listen to a word, the last word.
Not at all.
That you've got the photo of there. What would you then be dressing that with?
Once it's at this level, well, you can see the difference. So from this limb that's full of edema, because it's poorly vascularised, we just used 1 layer of tubular bandage. She had a failed fempop, still smoked. Just a nightmare patient, and you get them. So just 1 layer of tubular bandage, and just get her to elevate the leg. That's all we did.
NAD over that?
Absolutely, flavanol and NAD, and then over this, once you've stopped the flavanol after 3 days, 3 applications of flemazine here, you could go to flavanol then and leave it for 3 days with just a tubular, tule, like a Adaptic, Gelinet, nothing special, because she's still smoking, and the fempop bypass has failed, but the body is resilient if you can treat the pain. And we don't tend to treat the pain with opioids either. We get the family to do, the passive exercises. They're still smoking. We don't really take it to heart. And we leave it like that because she is going to die from peripheral vascular disease, still smoking. It's heartbreak. But such is the addictive nature of cigarettes. In the face of death, they still smoke. I said I would smoke at 80, so, that's coming closer than I like to think. So, in conclusion, we just need to keep it simple. Complex wounds, we need to refer early rather than later. If it's dry, moisten it. If it's too moist, dry it. Treat the underlying chronic disease rather than the wound itself. Okay? We need to look after one another. We need to look at the resources that are available, and you'll get all of these on with the notes. There are easily read documents, UMA.org, and these documents are great for understanding why we do things. Easily read. World Union of Wound Healing Society in Europe. Got to love the Europeans. Got more money than Australia has. And Wounds Australia, it's no longer ORMA, it's Wounds Australia. They've got the outcomes and care plans associated with venous leg ulcers and pressure injuries. But it's mainly a hospital approach. And then finally, you've got standards in wound management. We have to debride, we have to actually diagnose, look after one another, Instead of hauling a colleague over the coals for doing the wrong thing, people do the wrong thing because they don't know better. We can gently teach them, can't we? We can leave leaflets lying around that will educate them without being too severe. Too often these young ones get put off because, nurses are cruel. We're not cruel individuals, are we? But, nurses are still renowned for eating their young. So let's be kind and initiate a new generation of outcomes. And thank you very much for listening to me.